Hello. I'll be presenting on vascular insufficiency and chronic ischemia of the hand. Having a good understanding of the vascular anatomy is critical for proper treatment. Primary blood supply to the hand is through the radial and ulnar arteries, which arise from the brachial artery in the proximal forearm antecubital fossa. The ulnar artery gives rise to the common interosseous, which becomes the anterior and posterior interosseous. In the distal forearm, the radial artery can anastomose with these arteries, and they can also be a possible source of secondary collateral blood supply to the hand in cases of chronic ischemia. In the hand, the radial and ulnar arteries form the deep and superficial palmar arches. The superficial palmar arch is formed from the ulnar artery as it crosses the wrist. There is significant variability in the superficial palmar arch. In one anatomic study, a complete superficial palmar arch was found in 84.4% of specimens, while there is a complete deep palmar arch in 97% of patients. The deep palmar arch is formed from the radial artery as it passes dorsally to the APL and EPB tendons, then returns volarly in the palm after giving rise to the princeps pollicis artery, while the common digital arteries arise from the ulnar dominant superficial arch. The primary venous drainage of the fingers and hands is through the dorsal veins, which drain into the basilic and cephalic veins in the forearm. Ischemia is caused by one of three factors: vasospasm, occlusion, or a combination of the two. Vasospasm results from increased sympathetic tone, thereby narrowing the lumen and slowing blood flow, which can eventually lead to thrombosis. Ischemia is the result of loss of nutritional flow as well as thermoregulatory control. Patients with vascular disorders typically present into one of three categories. Acute traumatic ischemia is beyond the scope of this talk. Delayed via post-traumatic aneurysm, hypothenar-Hammer syndrome, or IV infiltration. Acute ischemia via arterial embolism or chronic ischemia from vasospastic Raynaud's, inflammatory arteritis, atherosclerosis, end-stage renal disease, and sepsis, as well as tumors, either congenital from arteriovenous malformations or acquired, glomus tumor, malignancy, and lymphedema. Examination should include a detailed history with cold intolerance, numbness, cramping, color changes, fingertip wounds, tobacco use, as well as acute or repetitive trauma, medical comorbidities such as diabetes or coronary artery disease or peripheral vascular disease. Physical exam should include normal examination with range of motion and musculature, while paying particular attention to vascularity, including skin color, temperature, turgor, capillary refill, peripheral pulses, either by palpation or Doppler. Additionally, looking for splinter hemorrhages, fingernail changes, or digital ulcers may be a sign of a more chronic etiology. You want to also palpate for masses or thrills, as well as perform an Allen's test, either visually or via Doppler. Diagnostic studies include duplex ultrasound, which is useful for providing real-time blood flow evaluation of larger vessels. Angiography is the gold standard, either CTA or MRA. Angiography also permits concomitant interventional procedures such as thrombolytic delivery or thrombectomy. MRA has several advantages over traditional contrast angiography. It limits the patient's exposure to harmful radiation and reduces the risk of nephrotoxicity and allergic reaction to contrast agent. Additionally, cold stress testing can be done by submerging the hand for 5 to 8 minutes in cold water. Then a laser Doppler is used to measure rewarming. Digital brachial index is similar to ankle brachial index in the lower extremity, and a value of less than 0.7 is significant for an occlusive problem, and reconstruction may be warranted. Uh, Less than 0.5 suggests critical ischemia. The photo on the right shows an arteriogram of a patient with recent ischemic symptoms in the thumb and index finger who had suffered thrombosis of the radial artery in the snuff box with subsequent embolization to the thumb and index fingers. Moving on to acute ischemia. Acute ischemia can be iatrogenic via arterial catheterization. Although isolated radial artery puncture, such as for a blood gas, is unlikely to cause ischemia of the hand, however, indwelling catheters have been known to cause permanent ischemic changes in up to 0.1% of patients. Radial artery harvest, rarely if inadequate collateral flow, which is preventable with preoperative Allen's tests. Systemic shock and high-dose vasopressors may develop tissue necrosis from hand ischemia, which is shown in the top image, while the lower image shows an ICU patient with signs of hand ischemia, including cyanotic fingertips and poor turgor, that resolved with warming the patient and removing the radial artery catheter without surgical intervention. There's also thromboembolism, as well as venous thrombosis. Although isolated DVT is rare in the upper extremity, patients with near total thrombotic occlusion of the deep and superficial veins can develop ischemic thrombosis, known as phlegmasia cerulodolens. Shock resulting in ischemia causes include urosepsis, shown in the lower photos, meningococcemia, and staph hemolyticus, shown in the upper photo, as well as vasopressor use, which can result in digital ischemia in up to 2% of patients. This can result in dry gangrene, which is treated with local wound care to prevent progression to wet gangrene. Treatment does not involve revascularization as patients have normal distal blood flow. It is very important to wait until complete demarcation, followed by eventual amputation once they've recovered from their illness. Delayed reconstruction is possible with flaps to preserve length, skin grafts for coverage, with the primary goal of preserving motion and function. End-stage renal disease resulting in ischemia. AV fistulas can rarely cause ischemic changes due to a Steele phenomenon, which is best addressed by the vascular surgeon often via distal revascularization with interval ligation in order to preserve the AV fistula. Prior to this, the ischemic neuropathy in the hand may be addressed by the hand surgeon with carpal tunnel release. Peripheral vascular disease associated with end-stage renal disease can present with severe ischemic pain and gangrene. Treatment is difficult and often involves pain control managed by the patient's primary care provider or a vascular surgeon. Revascularizing is difficult and most often addressed via arterialization of the venous system. Alternatively, an early amputation for pain control may be indicated. The amputation would be done in one stage with wide margins to assist in healing, while sacrificing limb length. The above photo is from a patient on dialysis. Thromboembolism, approximately 15 villi go to the upper extremity. The heart is the most common source. In the setting of AFib or a recent myocardial infarction, other sources include thoracic outlet syndrome, atherosclerotic plaques, subclavian or axillary artery aneurysm, traumatic or atherosclerotic, Takayasu's disease, or giant cell arteritis, mechanical problems in a graft, such as AV fistula or bypass graft, penetrating trauma, or catheter-related thrombosis. Presentation of macroemboli from the heart produce immediate symptoms of acute arterial obstruction with the 5 Ps of pain, pallor, pulselessness, paresthesia, and poikilothermia. Microemboli arterial, or is where multiple microemboli shower the distal arteries in the hand and can lead to Raynaud's. Diagnosis would be via arteriography. Treatment of emboli need aggressive addressing the proximal via either proximal arteriotomy and embolectomy using a Fogarty catheter. This is a catheter that is small enough to pass into the superficial and deep arches of the hand. There's also percutaneous intraarterial thrombolysis, as well as surgical revascularization. Cervicodorsal sympathectomy can provide relief for chronic pain from distal small vessel occlusion. Emboli from the heart are treated with immediate heparin therapy and long-term anticoagulation. Moving on to chronic ischemia. Raynaud's phenomenon was first described by Maurice Raynaud in 1862. It is a vasospastic disorder characterized by episodic vasospasm with reversible ischemia of peripheral arterioles. Diagnosis requires cold sensitivity as a trigger, followed by biphasic color change from white to blue during an attack. This is also associated with symptoms of paresthesias and burning pain. The prevalence is 1.6 to 7.5%. Risk factors include female gender, family history, smoking, and migraines. It's thought to be mediated by a sympathetic alpha adrenergic innervation, although the mechanism is poorly understood. It's exacerbated by endothelial cell dysfunction, including increased endothelin 1 activity and decreased nitric oxide activity. Raynaud phenomenon can be divided into primary, which is Raynaud's disease, where there is no underlying disorder and vasospasm alone, which typically has a benign course. There's also secondary Raynaud's phenomenon, in which there is an underlying systemic condition. The frequency of secondary Raynaud's is dependent on the underlying condition and is almost universal in patients with scleroderma. Other associated rheumatologic conditions include RA, lupus, Sjögren's syndrome, mixed connective tissue disease, as well as CREST. Additional conditions include hematologic disorders, mechanical injury from chronic vibrations, other vasospastic disorders such as migraines and Prinzmetal angina, as well as medications such as beta blockers and serotonin agonists. These patients need a more extensive laboratory workup, including a CRP, ESR, ANA, rheumatoid factor, as well as a referral to rheumatologists, as there can be significant morbidity, including digital ulceration and gangrene. Management of an acute Raynaud's crisis is often secondary to lupus. There will be acute extremity ischemia with associated joint pain and fever. Treatment would include stabilization of the patient, a rheumatologist consult, and potentially plasmapheresis. For addressing the digital ischemia, you want to have the patient undergo systemic vasodilation while watching the patient's blood pressure during this process. Nitroglycerin may also be directly applied to the ischemic digit. Pain control is of utmost importance, and patience while allowing the gangrene to demarcate. Management when there are no ulcers. The primary treatment is by a rheumatologist. Therapy for secondary Raynaud's should be tailored to the underlying condition. Behavior modifications include cold avoidance, smoking cessation, and avoidance of certain medications. Medications for management include calcium channel blockers, primarily nifedipine, iloprost, and phosphodiesterase 5 inhibitors. In scleroderma, you want to obtain a Doppler study to evaluate arterial flow, as well as if there is ulnar artery occlusion, which can assist in predicting future problems. Management of ulcers or painful recurrent attacks. You want to first put the patient through a Doppler warm stress test. This is completed via a baseline Doppler, followed by soaking the patient's hand for 20 minutes in a bath set at 110 degrees Fahrenheit, then a repeated Doppler exam. If the exam shows improvement, you can expect a good response to sympathectomy. If there is no improvement, the response to sympathectomy is not as predictable, however, it is still indicated. Angiogram with vasodilation for anatomy, as contrast arteriography requires a catheter to be induced and may cause vasospasm and vasospastic disorders. Additionally, you want to check for ulnar artery occlusion, as a reconstruction may be indicated. Sympathectomy can be undertaken either chemically or surgically. Chemically via Botox, which is less invasive, although there are side effects of hand weakness and paralysis. The mechanism of Botox is poorly understood, but thought to be due to preventing the release of norepinephrine at neuromuscular junctions, resulting in inhibition of sympathetic mediated vasoconstriction, preventing alpha-2 receptor recruitment in cold conditions, and inhibition of substance P mediated pain signaling. Studies show it helps with pain relief, increases blood flow to the fingers, thus ulcer healing, and improves function. Botox is injected on the volar aspect of the hand in subcutaneous tissue surrounding arteries and is repeated every 3 to 8 months. Surgical periarterial sympathectomy is a process where the periarterial adventitia is stripped to disrupt sympathetic tone. The stripping is undergone from the superficial arch out to the proper digital artery just proximal to the proximal phalanx. The nerve of Henle is also divided, that arises from the ulnar artery. It would also perform distal revascularization if there is a proximal occlusion and appropriate distal targets seen intraoperatively, and any ulcers would be debrided at this time as well. In the photo, there is an angiogram with a patient who has scleroderma with decreased flow in the common and proper digital arteries who underwent sympathectomy. Hypothenar hammer syndrome is a traumatic thrombosis of the ulnar artery in the palm. It is most common in males, smokers, and with repetitive hand trauma. The pathophysiology can be elucidated from the ulnar artery anatomy, which emerges from Gans canal. It becomes relatively superficial and susceptible to trauma, which can result in formation of a true aneurysm or pseudoaneurysm and subsequent thrombosis. Presentation would include a unilateral vascular insufficiency in the small ring or middle fingers. There may be a pulsatile mass at the level of the wrist, splinter hemorrhages in the nails, ischemic changes, and digital ulceration. The diagnosis can be made via angiography, and a pathognomonic corkscrew sign would be seen, as shown on the right. Treatment would begin non-operatively with behavior modification, such as smoking cessation. Medical management would include calcium channel blockers and aspirin. Antiplatelet and thrombolysis can be utilized in acute severe ischemia. Should the above not suffice, then surgical intervention may be indicated in the presence of an aneurysm, recurrent embolic events, and persistent symptoms. Procedures would include resection or ligation of the aneurysmal segment, or reconstruction with direct repair or with an interpositional graft. Arterial grafts are more physiologic and may have improved long-term outcomes. Donor sites include the lateral femoral circumflex, deep inferior epigastric artery, thoracodorsal, and subscapular artery. This is preferred in younger patient. However, a dorsal hand vein can be used as a vein graft in men. IV infiltration is an extravasation injury. It presents with erythema, induration, poor capillary refill, and blistering. Treatment would include removal of the vascular access device, elevating the limb, and applying a warm or cold compress. Surgical indications would be the presence of full thickness skin necrosis, chronic ulceration, persistent pain, while at the same time monitoring for compartment syndrome. Berger's disease is thromboangiitis obliterans. This is an inflammatory disease of the small and medium-sized arteries of the upper and lower extremities. It is not as often seen in the upper extremities. There will be characteristic corkscrew vessels on arteriogram, shown on the right, most commonly seen in young male smokers. The patient will present with claudication and signs of limb ischemia, including rest pain and ischemic ulcerations. Discontinuation is often the only definitive treatment. The diffuse involvement of small caliber vessels, bypass, and revascularization procedures are typically not successful. Often, the only option is amputation if disease presents with refractory pain, non-healing ulcers, or gangrene. However, the prognosis is good if patients are able to quit smoking. Atherosclerotic disease can present with chronic hand ischemia in up to 5% of all patients undergoing vascular surgery. The incidence of below elbow ischemia from chronic vascular disease is likely underreported, especially considering the increased prevalence of comorbidities associated with this, such as diabetes, end-stage renal disease, and systemic atherosclerosis. Around 5% of patients with chronic ischemia have upper extremity involvement. Diagnosis can be made with history and physical with complete vascular examination. Arteriography is the imaging modality of choice. Treatments include arterial bypass, which is the best choice for isolated occlusion and patent distal vessels. There's also arterialization of the venous system. This is considered a salvage procedure when no patent distal vessels exist. This technique reverses venous flow in the distal hand of affected patients. This is typically accomplished by an end to side vein graft from the radial or ulnar artery to a dorsal hand vein to provide retrograde flow through the vein to the distal hand and fingers. Valvulotomies, either with a valvulotome or by direct microsurgical excision, are critical to ensure reversal of flow. Balloon angioplasty can be performed as distally as the volar arch. Stenting is typically reserved for more proximal lesions, such as subclavian, because of poor patency rates with stenting of more distal occlusions. A systematic review out of Penn presented a treatment algorithm of chronic ischemia of the hand. They found in their review that sympathectomy, arterial bypass, and venous arterialization resulted in pain relief in 89, 100, and 100% of patients respectively, whereas successful wound healing occurred in 74, 93, and 75% respectively. When conservative measures such as medical optimization and rheumatologic treatment fail to improve chronic hand ischemia, resulting in intractable pain or non-healing wound despite the medical therapy, surgical intervention is an effective last-line treatment. An algorithmic approach can determine the best operative intervention for patients with chronic hand ischemia. Surgical planning would begin with imaging, such as duplex Doppler, MRA, or arteriogram. If there is no identified vascular lesion and the major vessels are patent, then a sympathectomy would be indicated. If there is a reconstructible segmental occlusion, then a bypass or interposition plus or minus a sympathectomy would be indicated. And if there is no reconstructible occlusions, then venous arterialization should be undertaken. And if recurrence of symptoms happens, then you would return back to repeat imaging. Moving on to vascular anomalies. Hemangiomas, there's infantile, which go through three phases of proliferation, plateau, and involution. Typically by age 7, 70% have fully involuted. They are GLUT1 positive. There is also congenital hemangiomas, rapidly involuting, which often involute at 6 to 10 months, and non-involuting. MRI can be helpful to differentiate these from arteriovenous malformations, although many will spontaneously involute without treatment. Treatment may be indicated if the hemangioma is symptomatic, including ulceration, infection, bleeding, or psychosocial factors. Treatment would include excision or cryotherapy. Arteriovenous malformations, the pathophysiology is primarily congenital, where it is sporadic and non-familial. There is an abnormal communication that causes shunting from the arterial to venous systems. This steals from the high resistance capillary bed and can lead to ischemia. This will present with a mass, a pink stain, dilated veins, and skin ulceration. There will also be associated limb heaviness that is aggravated with dependency and relieved with elevation. AV malformations can be diagnosed via either a pulsatile or palpable thrill from turbulence in the venous system. Braun sign, which is slowing of the heart rate during proximal compression. Imaging would include a duplex ultrasound, as well as CTA as the most important method, although MRI is becoming the new standard in pre-op evaluation. Most of these malformations can be managed medically. Surgical indications would be hemorrhage, painful ischemia or non-healing ulcers, congestive heart failure, or functional impairment. Treatment options include sclerotherapy, embolization, or excision. Notably, prior to excision, malformation should be embolized preoperatively, and excision should take place 48 to 72 hours later. In the photos, you see a high flow AV malformation with pain and ulceration, reconstruction of the ulnar artery with the reverse saphenous vein, and 1-year follow-up with no pain and good function and no sign of recurrence.